right? If the problem list or the medication list isn't up to date, we can't use that to populate should this patient be in the denominator of a measure. There are probably going to be requirements for the individual clinician to do this, but if we've seen where specialists or other non-primary providers have complementary information, but they're not updating a centralized problem list or medication list, that could affect the reliability of the data. Active versus historical information on a problem list, history of versus they've got it now. And then there's the bugaboo I think we're all facing is are we getting this data into a discrete queryable field? Does the clinician put the blood pressure values typed into a progress note instead of in the discrete fields? The LDL value or an A1C level is the lab report scanned and put in as an image rather than being put in again as a queryable field. Again, as a measure, for clinical processes, maybe it's another click to be able to pull that thing up. You can use it for clinical patient management. As a measurement person, this is the stuff that really makes me nervous. Finally, how do we know that, so how are we going to check this? I think some of the first things we're seeing about meaningful use, they're talking about physician attestation. Yes, I did this right. I mean, I'm not sure exactly what they're going to be attesting to, but I think we need to go beyond, think about how do we go beyond attestation. Assessing data complete, we could do it by looking at data completeness, outlier analysis. When somebody submits, when a clinician submits rates, are the rates reasonable? Should we pull a small sample of those that are outliers to not only validate the integrity of the data, but to also understand on a system basis what are some of the root causes or faults that we're seeing so that we can sort of build in error prevention into the system as a whole, not necessarily to play gotcha on individual submitters who are probably trying to do the right thing. A sample audit, again, pull data on a sample of submitters so that we can try to learn what's going on. So in conclusion, I think what we need to do to make sure that valid data comes out of EHRs, clear specifications, measurement, clear specification, measurement systems and reporting. We need to make sure that the data collection functionality has been rigorously reviewed across all of the dimensions that I discussed. And finally, we need to make sure that the workflows within the practices are, and use of the EHR itself is supporting our ability to be able to use the data within that system in order to be able to do performance measurement and reporting. So are there any questions of clarification?
Great presentation, Phil. Thank you. The certified auditors that NCQA trains, you made reference to them earlier in the presentation at the level of the health plan. Are those individuals trained so that they would also be going into a small practice setting and find out whether individual clinicians are using the EHR in a way as it was intended? Because I agree with you entirely. The thing that troubles me most is this issue of whether or not the clinician takes the time to use the drop-down menu, or whether they just go ahead and put it in the narrative section thinking that somehow that's going to, they're going to get credit for that, and they don't end up in the denominator the way we expected them to.
Yep. So in general, I mean, the auditors aren't going out to individual practices. In some programs, such as the California Pay for Performance program, they are going out to the physician groups and validating the data and auditing the data that the physician groups are reporting. Some of them are using the EHRs. Mm-hmm. One of the things that they're looking for is that sort of for the CSI fans, the chain of evidence, that what goes in and then how it gets processed through the mm-hmm. system. But right now, they are not, and there's very few places where there's somebody going out either to do validation or doing technical assistance. I think we see some programs such as New York's Primary Care Information Program, the Taconic IPA, MedAlly's work, where, and probably, if I didn't mention your program, it's not intentional, but where there are people going out and helping to rework the workflow such that it can support these programs. But I think that the thing about Taconic and PCIP is that they're trying to build in the measurement piece up front, and that's part of why the technical assistance to be able to capture coded data is built into that. Mm-hmm. That answer your question? Yes, yes. I mean, it's going to be a laborious process, and I don't see any way around it other than to, as more and more practices adopt EHR, somebody is going to have to go in and, at least initially and probably periodically thereafter, validate whether or not the use of the record is proper. Yeah, and I think that the tension we're going to see is between validating and trying to understand root causes of errors and improving the system from a quality improvement perspective. Mm-hmm. Mm-hmm.
Thank you, Phil. We'll now move to Jerry Hinckley from Davis, Wright, and Tremaine, our last speaker, and then we'll have some discussion with the board.
Thank you, Art. Yeah, let's see. I just want to make sure I'm pointing in the right direction. And then there's this little delay here, right. just to keep us on our toes. Well, first of all, I want to thank the organization for having me and organizing this panel. You know, one of the things that I enjoy about these kinds of experiences is kind of the offline interaction with the panel. I really appreciate Art's leadership here, and our prep meeting was worth the price of admission for this, so I appreciate that. Originally, and I also want to acknowledge the support of your staff, who really have been excellent, because we're not very herdable, and so this was they did as good a job as anybody could possibly do. Originally, I was going to be first and kind of set the tone for all of this, and then through the course of our discussions, it became very clear I was the spoiler, and so I got moved to the end, and I'll just try to make a few points. I think it drives very nicely from the remarks of the other panelists about kind of, well, where are we now, particularly in the context of the NHIN, on the topic that we're addressing today, which is integrity, authenticity, and accuracy of that information. Do this. There we go. I think the overall point I want to make today is that the information is going to be derived from any record that is transmitted through the NHIN or through local, regional HIEs, it falls upon the recipient of that information to decide how valuable it's going to be. What you're going to see, and I'll drill down a little bit more on the DRSA that Holt has introduced, is that you're not receiving any assurances regarding accuracy, integrity, or completeness of that information. And I think the point is, what do we do in order to create a better framework for users of that information, very similar to kind of the content that Phil just took us through. And I think my argument is going to be that we're going to need to establish some means to develop the standard of care for the practitioner around HIE sourced and PHR sourced data, and that ultimately somebody is going to be left holding the bag. And wait till slide 4. So let's turn to the DRSA for a second. I had the distinct honor of being one of the principal authors of the Markle Model Data Exchange Agreement that took quite a bit of time to develop, and was the, I think some important underpinning for the DRSA and other health information exchange agreements that are in use around the country. And from that experience, whenever a new agreement comes out, and I haven't been directly involved in the development of the DRSA, I'm always interested to see how yet another group addresses the problems that we struggled with during that early work. And the interesting part about data sharing agreements is that no one wants to take responsibility for anything and have any liability, but it all needs to be perfect. And in the DRSA, there's a specific representation by sources of information that that all you're getting is what was available at the time for exchange. There are express disclaimers regarding clinical accuracy, content, completeness, that the information is going to be available tomorrow that was available today, and you really kind of get it as is, where is. It's kind of like buying a used refrigerator. And the participants, acknowledge that as recipients of this information, that they know it's not complete, and that it's what's available and what's exchangeable at that time. So, kind of, where does that put us? Well, I think as stated in the DRSA, it's the provider who's responsible for obtaining all necessary information related to the care decisions and to making those decisions, and to addressing utilization management and quality management with respect to any patient. And the DRSA tells us that no NHIN participant assumes any role in patient care by virtue of being in the chain. This is not to criticize this, because having been there, in many instances, this is the best you're going to get. So with that, where are we? So, I want to turn a little bit to kind of PHRs, because that's even more wrinkly. I mean, Janet made the point of, how are you going to make sure the doctors are using this right? Now you're actually giving it to the patient. We all see our own physical and health conditions, through our own filters. And sometimes when you get the message from the doctor that travels through Google into your PHR that I think you're a drug addict, you're probably not going to leave that in your record, if you have any editing capacity at all. And so, there are a couple of kinds of PHRs. One of them is, it's just a collection of records that come from third parties, and those are often called exclusive. And so you would get, I think the typical example of that is a whole bunch of PDFs of lab reports and, other things. And then the converse of that is what they call the inclusive, which is kind of the aggregate self-managed PHR. And I think that's what, as consumers, that's what we'd like. We'd like to have something that is more personal, that allows us to collect things other than, effectively official records of our health, because it helps us understand, what's going on with us physically. And so, PHRs that allow you to, do, web-based research and find out, and kind of wiki your condition, and then save that information into your PHR and create something much more useful for you personally, I think has a lot more commercial appeal. But what happens there is that you have, editability. You may lose direct source data, so that, for example, it may be a summary of a lab report. You actually don't have the lab report anymore. And it's very difficult, I think, from a legal standpoint. If a practitioner relied on patient-supplied information inappropriately, to nail the patient later on, that, well, you did this and I relied on it. People much smarter than I have always said that, our patients give us half of the information that we need and lie to us all the time. And so the PHR is going to follow that norm, I think. And so it kind of falls to, well, what are you going to do with that reality?